Hello students, I am Dr. Harmeet Goel, your Obs Gynae faculty, and I am here to do an FMGE Jan 2024 accurate Obs Gynae recall, because after the exam in a day or two, the students are able to give us more and more questions. So I decided to do it again, because so that more and more questions you are being familiar and you can cross check your answers. So I am discussing the recall of Obs and Gynae questions that was asked in FMG exam Jan 2024. Now the first question that was asked was, what was the correct sequence of the breast changes, that is mammogenesis, galactokinesis, galactopoiesis or lactogenesis, galactokinesis, galactopoiesis, lactogenesis, mammogenesis, or mammogenesis, lactogenesis, galactokinesis or galactopoiesis. So I have already been discussing this in my sessions. So mammogenesis, then followed by lactogenesis, followed by galactokinesis, followed by galactopoiesis. This is the correct sequence. Mammogenesis means preparation of the mammary gland for milk secretion. This is majorly done by two hormones, estrogen and progesterone. It prepares the breast for milk secretion, and for the first trimester of pregnancy, estrogen and progesterone are being secreted by the corpus luteum of ovary. After that, the full-fledged placenta takes over the function and starts secreting the hormones. Then comes lactogenesis, which is being done, which means milk secretion, synthesis of milk within the breast. This milk is not released until the child is born and baby starts suckling the breast. Now, prolactin. Prolactin is secreted from which part of the pituitary? From the anterior pituitary. Then comes the galactokinesis. Galactokinesis means milk ejection reflex, and the important stimulus for milk ejection is suckling reflex by the newborn baby. So galactokinesis is brought by oxytocin hormone, which is being secreted from the posterior pituitary of the mother. Then comes the galactopoiesis, which means maintenance of lactation. Maintenance of lactation. This is done by prolactin hormone. So the sequence is mammogenesis, lactogenesis, galactokinesis and galactopoiesis. So this one, third option is the correct answer. Next. Which part of the placenta is formed by the mother? That means maternal contribution to the formation of placenta is by, that is deciduo parietalis, deciduo basalis or chorionic plate. So the correct answer is that placenta has two origin, that is from the maternal side and from the fetal side. From the maternal side it is deciduo basalis, maternal side it is deciduo basalis, and fetal side is chorion frondosum. Fetal side is chorion frondosum. Endometrial lining in pregnancy is called as decidua, and the part of the decidua which is forming the placenta is the decidua basalis. The part which is covering the implantation site is decidua capsularis, and the rest of the uterine cavity, it is decidua parietalis. So decidua basalis is the one which is forming the maternal side of placenta, which is the hormone responsible for decidulization. So the answer is progesterone. Progesterone is the hormone that is responsible for decidulization. 80% of the placenta is fetal in origin. 80% of the placenta is fetal in origin. Next. Multigravida patient, she is pregnant with a history of previous cesarean section. Now, which case you will allow a vaginal delivery? That means they are asking about VBAC. VBAC means vaginal birth after a cesarean section. So, this is only possible if there is a lower segment cesarean section was done and it is not a recurrent indication for the next cesarean. Like if there is first cesarean was done for a contracted pelvis, naturally the pelvis is not going to improve. So the next time again she has to go for a elective cesarean section. Now if there is a classical cesarean, in that case there is increased chances for it to rupture in the next pregnancy. So it has to be a recurrent indication for a next planned cesarean section. Now if there is a scarred uterus and presently in the pregnancy it is a breech presentation, so any malpresentation, okay, is a contraindication for VBAC. So remember that. So there is something wrong in the recall of the question. Either they have asked about the like there is some confusion in the question and the options given to me. So if it was a like classical cesarean section in the option, then that is a contraindication. You cannot allow the delivery, vaginal delivery. If it is a scarred uterus with breech presentation in the present pregnancy, again you cannot allow, because breech, like you cannot do any manipulation, it will lead to the scar rupture. If it is a vertical cesarean section, like then you can allow a delivery. So if we get again the correct options, only then we will be able to tell you what is the exact answer. So if there is a scarred uterus and there is a present pregnancy, if it is a preeclampsia, we can allow a normal delivery because it is not a recurrent indication for cesarean section. Next, 22 weeks contraceptive failure came for an abortion according to new MTP Act. Like two doctors' opinion is given if the pregnancy is between 20 to 24 weeks. This is correct. Okay. But mind it, this is reserved for those patients where the fetus has got any congenital malformation, or if she is a rape victim and the pregnancy has crossed beyond 20 weeks. Only then two doctors' opinion is recommended. But if there is a contraceptive failure, contraceptive failure is an indication for the first trimester MTP. Now, if the pregnancy has gone up to 20 weeks and it was a contraceptive failure, then that means the correct answer to this question, this case will not be given to the medical board. If the patient is a case of fetal congenital malformation and pregnancy has gone beyond 24 weeks, or if she is a rape victim, only then this case can go to the medical board. Okay, medical board. If the pregnancy has gone beyond 24 weeks and she is a case of rape, she is a rape victim, or she is carrying a fetal congenitally malformed fetus, congenital malformation which is not compatible with life, then that case goes to the medical board, which consists of a gynecologist, pediatrician, radiologist and a gazetted officer appointed by the state government or union territory. Okay, so this is out of the scene. Take permission from super determinant from the hospital. Again, this is out of the scene. Two doctors' opinion, because contraceptive failure is always an indication for doing a first trimester MTP that is less than 12 weeks. Okay, contraceptive failure usually is not an indication for a second trimester MTP. If it was a condom failure or she failed to take up OCP, she should have come for an emergency contraception, which can be given in the form of a levonorgestrel pill if she comes within 72 hours, or IUCD insertion can be done if she comes within 5 days of unprotected coitus. So in this case, according to my answer, because I am doing an accurate recall of this discussion of this Obs Gynae questions. So it will be, if the fetal malformation is there in the present pregnancy, then even if it is a contraceptive failure, we can do MTP. Next, maternal mortality does not include. Maternal mortality, again, I have already discussed in my guess paper series. And even in the Obs and Gynae test and discussion, I have discussed about maternal mortality. Maternal mortality is maternal death. Mortality always means maternal death that is occurring within 42 days of delivery. But mind it, that should be the pregnancy related causes. Pregnancy related causes like postpartum hemorrhage, like sepsis, as a result of pregnancy or delivery, like that of like ectopic pregnancy, which is also a pregnancy outcome. The patient is a neglected case. She presented with shock. There was a history of amenorrhea and patient could not be revived. Again, that comes under the maternal mortality rate. So death occurring in the postpartum 14th day, that is again included in the maternal mortality. Okay, but death of a pregnant woman, due to accident is not maternal mortality. Okay. Next, a clinical question was asked. 15-year-old girl was brought by her mother with complaints of primary amenorrhea and not attaining menarche. There is widely spaced nipples, short stature. What is the karyotype? So this is a question of Turner syndrome. Of course, every time when we take up any revision session or recall session or a rapid revision or any guest paper series, we always talk about Turner syndrome, and I don't think any one of you might be finding any difficulty in solving such straightforward questions. So the karyotype of Turner syndrome is 45XO, where the female is a short stature female. There is congenital webbing of neck, there is a cubitus valgus deformity, there is no breast development, and the karyotype is 45XO. There is congenital heart disease, which is bicuspid aortic valve or coarctation of aorta. So much you know about Turner syndrome. Next, what is the management of uterine inversion? That is acute inversion of uterus, which is an obstetrical complication, and usually this occurs due to mismanaged third stage of labor. Mismanaged third stage of labor, and patient goes into shock. That is initially the neurogenic shock, because when the uterus is out, the pedicles get stretched, and later on it becomes a hemorrhagic shock. And usually the cause of death in this question is the hemorrhagic shock. Cause of death in this cases are the hemorrhagic shock. So if the acute inversion has occurred, whether the placenta was intact or placenta has been delivered, no, the first step is always call for help, start IV line, start the ringer lactate drip, arrange for the blood, and manual reposition of the uterus. Patient has to be shifted to operation theatre. Always shift the patient to operation theatre. No oxytocin, no management should be done in the labor room. Okay, so shift the patient to OT, take the consent, and ask the anesthetist to give the general anesthesia. There is manual reposition of the uterus back into its anatomical position, and followed by uterotonics, the agent that can contract the uterus. So never ever make a mistake to give oxytocin. O'Sullivan's is a hydrostatic method, where with the hydrostatic pressure you are putting up the uterus back into its anatomical position. I have done my MBBS from Lady Harding and post-graduation from Safdarjung Hospital, and I have never seen like hydrostatic method being employed as the first method to deal with this cases. So it is manual reposition of the uterus back into its anatomical position in OT under general anesthesia, followed by uterotonics. Uterotonics is agents that contract uterus, oxytocin or prostaglandin injection or methergine injection, ergometrin, whichever is available, or whichever contracts the uterus. So usually there is an IV fluid which is running, so we add the oxytocin in that. That is fair enough to cause contraction of the uterus. Huntington's method is a surgical method of reposition. So the maneuver done is a Johnson's maneuver where reposition of the uterus occurs back into its anatomical position, and this is done by manual method. Next, what is the gold standard investigation for endometriosis? This you already know. So many times I have discussed this particular question even in the rapid fire revision of Obs and Gynae. The straightforward I have discussed and the straightforward question has come. Endometriosis means presence of endometrial tissue outside the uterine cavity, and most common site is the ovary. That is the most common site, and rare site is the CNS. So what is endometriosis? Is chocolate cyst of ovary, or there is peritubal peri-ovarian adhesions, or there is scattered endometriotic implants in the peritoneal cavity. So the most common symptom is the pain, and pain of congestive dysmenorrhea is the most common symptom. Other features can be dyspareunia, that is painful coitus, chronic pelvic pain, or menorrhagia, and important presentation can be infertility. So if you are working up a patient of infertility, you will find around 40 to 50% cases of endometriosis are responsible for unexplained infertility. So laparoscopy remains the gold standard investigation because that will confirm your diagnosis. Number 2, you can do therapeutic treatment. Diagnostic laparoscopy can be converted into therapeutic laparoscopy if you have made the diagnosis of endometriosis. How you can manage the case? Young patient with endometriosis, laparoscopy is the gold standard, where with laparoscopy you can do ovarian fulguration of the ovary if it is an ovarian cyst, leaving the normal ovarian tissue behind. If the size of the cyst is more than 4 cm, ovarian cystectomy can be done. And peritubal peri-ovarian adhesions can be done by adhesiolysis under laparoscopic guidance by use of the laser or by cautery. Okay, and we can burn the endometriotic implants by laser or cautery. So gold standard investigation remains the laparoscopy. Next, Turner syndrome features, webbed neck. This was again a very straightforward question. Next, Emsel's criteria is used for trichomoniasis, candidiasis, bacterial vaginosis, or chlamydia. So the correct answer, Emsel's criteria, is for bacterial vaginosis. Bacterial vaginosis is when the lactobacillus is replaced by Gardnerella vaginalis or Mycoplasma or Haemophilus. Okay, so that is, like bacterial vaginosis. And the Emsel's criteria includes when the pH is more than 4.5. So the lactobacillus is the bacilli which is converting the glycogen into lactic acid, making the pH of vagina acidic, that inhibits the growth of pathogens. So whenever lactobacillus has been replaced, the pH of the vagina goes towards alkaline, and which favors the growth of these Gardnerella vaginalis and other microorganisms. So there is fishy odor, smell. This bacterial vaginosis is not STD, remember. There is a fishy smell. There are clue cells on the saline microscopy. Clue cells means the epithelial cells where the bacteria are laden. Okay, you can see under saline microscopy. So whiff test is positive for bacterial vaginosis. That is, you take the sample of the vaginal discharge on a slide and put KOH, you can see, you can smell, there is a fishy smell. This is bacterial vaginosis. And the drug of choice for bacterial vaginosis is metronidazole. It is not STD, so there is no need to treat the partner. Next, 25-year-old lady came to the OPD with unprotected sex on 5th day. She has come to you, and what is the most likely contraception suggested? If the lady comes within 72 hours, then postcoital contraception that is given is the hormonal. In the hormonal, which is applicable within 72 hours, the preferred is LNG pill, which is 1.5 milligram single dose. This is preferred. And there can be OCPs, which is 4 tablets after a gap of 12 hours, 4 tablets. Then it can be RU 486. But this female has come on the 5th day of the coitus, so I prefer giving IUCD insertion in this case. Which type of IUCD is the copper T? Levonorgestrel pill is not recommended because she has passed the 72 hours of unprotected coitus. You should also know about ulipristal. Ulipristal is also an emergency contraception. Dose is 30 milligram. This can be given within 5 days of unprotected coitus. This ulipristal is selective progesterone receptor modulator. And another use of ulipristal apart from postcoital contraception is in the fibroid uterus, where the dose is 5 milligram. It's given daily for 6 months, which will lead to shrinkage in the size of fibroid. So in this question, the answer is IUCD. Which type of IUCD is copper T? Remember, Mirena is not an emergency contraception. Next, all of the following are true about cutoff value for semen analysis except sperm count less than 25 million, motility progressive 32%, morphology 4%. So progressive motility and morphology are correct, but the cutoff value for sperm count is, so the WHO cutoff limit for sperm count, amount, count, motility and morphology. The cutoff values are 1.5 ml, 15 million per ml, motility 40%, progressive motility 32% and morphology 4%, which is the most important indicator for in the semen analysis when you are preparing the patient for IVF. Is the fertility indicator in semen analysis is the morphology, then is the motility, and then is the count. So cutoff limit for WHO, according to WHO, for the cutoff value when you label the patient as infertility is 15 million per ml. Next, drug that is absolutely contraindicated in pregnancy: paracetamol, captopril, cefixime or azithromycin. Azithromycin group like roxithromycin, azithromycin can be given, cefixime is again given, and paracetamol can be given. So captopril is contraindicated because ACE inhibitors are contraindicated in pregnancy as it causes teratogenic effects. If it is given in the 2nd or 3rd trimester, then the ACE inhibitors, that is angiotensin converting enzyme inhibitors, causes placental insufficiency or fetal hypoxia. So it is not preferred neither in the 1st, 2nd or 3rd trimesters of pregnancy. Next, how much dose of the anti-D immunoglobulin is required in an Rh negative mother at the time of chorionic villus sampling at 11 weeks. So this I have already told you. Rh negative mother means she does not have a D antigen on her red cell membrane, and if she is carrying an Rh positive baby where the presence of D antigen are there, so this fetal RBC can enter into maternal circulation if there is any MTP, abortion, ectopic pregnancy or any invasive procedure like chorionic villus sampling or amniocentesis or chordocentesis you are doing, or external cephalic version, then immunoglobulin has to be given, which will bind to this antigenic sites and block this any antigenic stimulus to the maternal immune system. So dose is, if anything is been done, abortion, MTP, like if there is ectopic pregnancy or if there is, like any invasive procedure you are doing, then the dose of anti-D immunoglobulin is 50 microgram intramuscular. Okay? Anti-D immunoglobulin immunoglobulin. If it is after 12 weeks, then the dose is 300 micrograms of anti-D immunoglobulin. So, 10 micrograms of anti-D immunoglobulin is able to neutralize, like 1 ml of fetal RBC. Okay. 300 micrograms 300 micrograms is able to neutralize 30 ml of fetal whole blood or 15 ml of fetal RBC. Okay, remember this. So this is 50 micrograms intramuscular dose. 300 micrograms is given if the mother has delivered an Rh positive baby and she is ICT negative. Then it should be given within 72 hours intramuscular of the delivery. McRoberts maneuver was done for shoulder dystocia and it failed. What is the next step in the management? So, shoulder dystocia occurs in cases of macrosomia baby. Macrosomia is a, a fat baby, to a diabetic mother. Because of this, so much of hyperglycemia, the baby puts on weight. So macrosomia is diagnosed by ultrasound, that is, like abdominal circumference more than 95th percentile for that gestation age, and management is usually an elective cesarean section. But if the patient has landed up, she has not got any ultrasound done, she has not been, not gone for an antenatal checkup, and she has just landed up in the labor room for delivery, where we see the cases in the clinicals. So in that case, the head of the baby is born and the shoulders are the one which get stuck up. So that is what is shoulder dystocia. So we do not apply fundal pressure. That is absolutely contraindicated, which is very important question. Now, next is we can apply suprapubic pressure and we can perform the McRoberts maneuver, where there is flexion and abduction of the thighs of mother in order to increase the space so that the shoulders can be extracted and delivery can be conducted. If the McRoberts maneuver failed, then the next maneuver which is being done is a Woods corkscrew maneuver. Woods corkscrew maneuver, Gaskin's maneuver is the next one, and the last maneuver to be done is the Zavinelli's maneuver, where you put the fetal head back and perform a cesarean section. And last one is clidotomy. Nowadays, clidotomy is usually not being done. So, answer to this question is Woods corkscrew maneuver. Now, which nerve is injured in McRoberts maneuver is lateral cutaneous nerve of thigh. This is again a PG question. Which nerve is damaged in performing a McRoberts maneuver is lateral cutaneous nerve of thigh. Next, a mentally ill pregnant female, who will give the consent for MTP? Legal guardians, doctor, self, or the partner? Neither the doctor nor the self nor the partner. It is the legal guardians of the patient who will give the consent. Next, in which infection treatment of male partner is mandatory? So they are asking about STD where we treat the male partner. So the answer to this question is trichomoniasis, which is an STD caused by protozoa, which is a flagellated microorganism, and it produces a greenish color vaginal discharge. There is foul smell, and on examination there are strawberry spots in vagina, and treatment is metronidazole 400 milligram BD for 7 days to both the partners. So the correct answer is trichomoniasis. Next, a female presents with curdy white vaginal discharge, and organism causing this condition presents as a pseudo hyphae. So this is what is a pseudo hyphae. pseudo hyphae, you see pseudo hyphae. Okay, so this is candidiasis. Candidiasis, there is a thick, curdy, white vaginal discharge which is given in the question. Thick, curdy, white vaginal discharge. So there are 3 questions from the topic of vaginal discharge. So when I was taking a rapid fire revision of Obs and Gynae, I said this is just a 5 minutes topic, but there are 1 or 2 questions definitely being asked. So there are 3 questions asked. Amsel's criteria, thick, curdy, white vaginal discharge, candidiasis, and then which is an STD, that is trichomoniasis. So bacterial vaginosis, candidiasis and trichomoniasis, all 3 microorganisms, they are asked from the vaginal discharge topic, which is just a 5 to 10 minutes topic, but there are 3 questions which is very, very important. So good, I think all of you must have done this question. One was Amsel's criteria, bacterial vaginosis. Number 2, where to treat the male partner, trichomoniasis. And number 3, thick, curdy, white vaginal discharge with pseudohyphae, that is candidiasis. Next, POP classification reference point is always the hymen. So when I was taking up this topic, so I was always teaching my students that remember POP. If you don't remember the very much details, at least remember the reference point. POP means pelvic organ prolapse. Pelvic organ prolapse. So the reference point is the hymen. Next, which of the following organs is most commonly affected in genital tuberculosis? Again, this is a very, very simple and straightforward question. The answer is fallopian tube. 90% of the genital TB, 90% of the genital TB, fallopian tube is affected. Okay, and 40 to 50% is the uterus causing endometritis. Around 30 to 40% is the ovary. It is causing the like oophorytis. So after a treated genital tuberculosis, again the presentation of the patient can remain as infertility, because the epithelium of the fallopian tube is the ciliated columnar epithelium, and maybe the cilia are damaged that cannot regenerate. So another presentation of a treated case of genital tuberculosis can be pregnancy. So usually in this case we find there is a lead pipe appearance of fallopian tube, or there is a beaded appearance of fallopian tube, or there is a tobacco pouch appearance, or there can be cornual block leading to infertility. Next, female with low socioeconomic status, wife of a truck driver complains of a white discharge from the vagina, and what do you do for screening of cervical cancer at district level hospital? I think it's a very simple straightforward question, that is a pap smear is the answer. So pap smear can be done by conventional method, where there is an Ayers spatula and a cyto brush. You take the sample from the lip of the cervix and make a smear on the slide, and number 2, you put in the cervical canal and make a smear on the second slide. So you you use a fixative material, that is 95% ethanol plus ether. And there is also a liquid based cytology, where in this there is a methanol. If you compare the results of the liquid based cytology is much better. Fine. So pap smear is a screening test. Remember, what are the other screening tests? Visual inspection under Lugol's iodine, Willi, and HPV DNA test. Which is the best test nowadays is HPV DNA test, but it is very, very usually comparatively a costly test. Then next, for the mass screening, the most cost effective test is a VIA test. Okay. Next, a female is on combined oral contraceptive pills, forget to take 2 pills in the 3rd week. What will you advise her next? Take the next pills in the next 2 days and continue without a break. Reassurance, start a new pack with additional barrier method for 7 days. It depends which tablets she has forgotten. Okay. Now, this is the table of the missed oral contraceptive pill flow chart. If she has missed 2 tablets in the 3rd week, then she should take the missed pill and she should start a new pack immediately, and additional contraception for for the next 7 days. Next, 22 weeks ultrasound shows low-lying placenta. Reassess the ultrasound at. So always remember, reassess ultrasound should be done at 32 weeks to do the localization of placenta. At 22 weeks, we cannot comment that it is placenta previa, because the definition of placenta previa starts after 28 weeks. So that is third trimester. So third trimester ultrasound will localize the placenta. So for placenta localization, a third trimester ultrasound is recommended, because at 20 weeks or 22 weeks, if it was low-lying placenta, then as the pregnancy continues, the placenta site is also shifted up. So what you are feeling at 22 weeks low-lying placenta, maybe at third trimester repeat ultrasound, it may become the fundal site. Okay, so your management, whether to plan a normal vaginal delivery or a planning for an elective cesarean section, should be done after you confirm it in the third trimester. So I am going to mark 32 weeks as my answer. A female of 80-year-old used to do strenuous exercise and complains of involuntary urine leak during the workout. So involuntary passage of urine while coughing, while sneezing, while straining, that is stress urinary incontinence. And stress urinary incontinence is when bladder neck prolapsing in the vagina. For this, the best treatment is TOT, transobturator tape or transvaginal tape. Next, a pregnant woman feeling like fainting while lying down, it is better while sitting or turning to the side. So which is the cause? Inferior vena cava compression, superior vena cava compression, morning sickness or hypertension? These two are ruled out. So these third one. So answer is inferior vena cava compression. As in this diagram, you can see, if she is lying in the supine position, there is inferior vena cava. So gravid uterus can compress upon the inferior vena cava, and the patient can have a feeling of fainting, feeling of collapse, feeling of syncope, because majority of the cases, the collaterals, venous collaterals get open up and nothing happens to the patient. In some of the cases, the patient can feel fainting, collapse or syncope. So this can be, like corrected by asking the lady to take rest in the left lateral position so as to avoid the inferior vena cava compression. Next, how much amount of glucose is given in screening for diabetes in pregnancy in India? So in India, the screening is done by DIPSI criteria, that is Diabetes in Pregnancy Society of India. So in this case, study group of India. So in this case, you give 75 grams of glucose, and ideally it is done at the first visit and repeat is done between 24 to 28 weeks, because that is the time where the insulin resistance is at its peak. So 75 grams of glucose, and you take the blood sugar levels after 2 hours. Cutoff value is less than 140 milligram per deciliter. If you're doing by glucose challenge test, again that is done with 50 grams of glucose, and the cutoff value is taken after 1 hour. It is less than 140 milligram. If you go by International Association of Diabetes in Pregnancy study group criteria, where 75 grams of glucose is been given, and you take fasting values 1 hour and 2 hours. So cutoff value is 92, then less than 180, and then 153. So the correct answer, if you do the DIPSI criteria or you do the IADPSG criteria, it is 75 grams of glucose. So the correct answer is 75 grams of glucose, which I have already discussed in the rapid fire revision of Obs and Gynae just before the FMGE 2024 Jan exam. Next, priming gravida at 1 p.m. was 5 centimeters dilated cervix, and at 4 p.m. after 3-4 hours later, it was 6 centimeters dilated. Now, rate of cervical dilatation in primigravida is 1.2 centimeters in 1 hour. So, in 3 or 4 hours, she should have been around 9 centimeters. So, this is what is a slow progress of labor. So, when I have discussed the partogram, I have already discussed the progress of labor. In the partogram, like if there is a dilatation curve from 4 centimeter, we start plotting the cervical dilatation and there is a descent. So it goes to the alert line. This is zone 1. So the graph should stay on the alert line or left of alert line, and this is a descent. This is dilatation, this is descent. If it crosses or goes in zone 2, which is likely in this case, so this means the progress is slow. Progress is slow and intervention has to be done. Intervention in the form of oxytocin or ARM if the contractions are mild, and if it is CPD, then you have to do a cesarean section. If this graph goes into zone 3, that means it is obstructed labor and you have to do an immediate cesarean section. In this case, the graph is in zone 2. Graph is in zone 2 where there is an slow progress, so intervention has to be done in the form of oxytocin or ARM, that is medical or surgical augmentation of labor. It is not induction, it is augmentation of labor. So according to this question, the intervention has to be done. Some students were saying that ARM, oxytocin and reassess after 2 hours was written. If that was written in the option, I am going to mark ARM, oxytocin and reassess in 2 hours. No need for wait and watch and no need to go for a cesarean section. With this intervention, the labor will progress. Next. A male came to OPD with complaints of sinusitis, breathing difficulty. He has history of infertility for past few years. On examination, there is thoracic cavity organ on opposite side. What is the likely diagnosis? Where there is sinusitis, breathing difficulty and there is infertility. This is Carter-Jenner syndrome. Next question. A pregnant female. On the same day, students are not able to recall all the questions. There were around 35 to 37 Obs and Gynae questions came in this FMG exam. It is not less than 35. So, Obs Gynae is always a big subject while you're writing any exam. Pregnant women with the first trimester of pregnancy has deep vein thrombosis. She needs to be put on anticoagulant. Which will you give? So in the first trimester, we prefer giving the heparin because heparin do not cross the placenta. So less than 12 weeks is heparin and 12 to 36 weeks it is warfarin. Next. Condyloma acuminata in a pregnant female, what will you do? TCA, trichloroacetic acid application, no. It is excision, no. Oral acyclovir, no. It is cryotherapy. It is caused by genital warts. This is HPV 6 and 11. Next, folic acid therapeutic dose. Pregnancy, premature delivery or diabetes, always therapeutic folic acid, which in the form of 4 milligram or 4000 micrograms is given 2 to 3 months pre-conception before planning the pregnancy, and it should continue in the first trimester of pregnancy. After the first trimester is over, in the second trimester, in the third trimester and in the lactation, we give iron plus folic acid, where iron is 60 milligram of elemental iron and 0.5 milligram of folic acid. Okay. Next, pregnant female with asthma and hypertension, what drug you will give? IV labetalol, oral nifedipine, ACE inhibitors or oral labetalol. So the answer to this question is calcium channel blocker, oral nifedipine. Next, which of the following is ideal time to check for the nuchal translucency ultrasound? Aneuploidy. For aneuploidy, it is 11 to 13 weeks. Which of the following is the investigation of choice to diagnose ovarian torsion? ovarian torsion. Which is the type of ovarian cyst that undergoes torsion? Is the dermoid cyst most commonly. And next is mucinous cyst adenoma. Mucinous cyst adenoma. So the color Doppler ultrasound is fair enough to diagnose the ovarian torsion. Next, a patient in labor supposed to undergo a cesarean section. She was given oxytocin 3 hours ago. Now her SpO2 is 93%. What will be the first step in management? Is always stop the oxytocin, start the ringer lactate, plain drip, give oxygen to the patient, and it will get corrected. Next, EBRT. EBRT is external beam radiotherapy that we prefer giving in cases of cancer cervix. So this is containing cobalt 60. Next, which of the following drug is preferred in the treatment of postmenopausal female with breast cancer? So the answer to this question is tamoxifen. Image-based question on omphalocele was asked. Then, which appendicular carcinoma is most commonly associated with pseudomyxoma peritonei? It's purely a surgery question, but why I have mentioned here is because mucinous cyst adenoma of the ovary is also associated with pseudomyxoma peritonei. Anemia Mukt Bharat, iron folic acid. So there is always an overlap of 2-3 questions of Obs Gynae with PSM, 1 or 2 questions with pediatrics, or 1 or 2 questions with pharma. So there is always an overlap whether you count it in gynae or you count it in the other subject. Question correct hona chahiye, kisi mein bhi count karo. So anemia mukt bharat iron folic acid dose is 60 milligram of elemental iron and 0.5 milligram of folic acid daily. Next, a pregnant lady with 2 months amenorrhea comes with headache, fever, and was diagnosed with Plasmodium vivax infection. Treatment in this case, quinine, doxycycline, primaquine, or artesunate. So the answer is quinine. Iron absorption is hindered by which of the following? Lemon, gooseberry, pickle, and sprouts. This contains vitamin C, and vitamin C increases the iron absorption. So the answer is T, which inhibits the iron absorption. During the routine antenatal checkup, it was found that expectant mother is on strict vegetarian diet. Which of the vitamin deficiency is most likely to be seen? Is the vitamin B12 deficiency. So that's all from Obs and Gynae Accurate Recall session. Thank you. Hope this session was useful to you.